All right, we are about to dive into one of the most clever and honestly most controversial ideas in medicine. It's this story about a perfect-sounding theory that just smacks right into messy, real-world clinical data. And it all starts with a problem that can be life-threatening. Today, we're talking about the albumin booster.
So, picture this. You're in the hospital. You have a patient who is just drowning in their own fluid. They're swollen, they can't breathe well. You give them a really powerful water pill, furosemide, which is the go-to drug, and nothing. Crickets. The drug just isn't working. This is a super common and incredibly dangerous situation. So, what do you do now?
Well, for years, this really brilliant idea has been floating around. What if you could just give the diuretic a little boost? The idea is simple. Add albumin, that's the main protein in our blood, right into the IV with the diuretic. The hope is that it'll just kickstart the whole process and get that fluid moving. On paper, it sounds flawless.
So, let's break down why this idea was so attractive in the first place. The theory behind it is it's beautifully logical. It's supposed to work in two key ways. First, you have the fluid magnet idea. You infuse albumin, and because it's a big protein, it acts like a sponge in your blood vessels, pulling all that excess water out of your swollen tissues and back into circulation where it can be dealt with. Second, and this is maybe even more important, albumin acts like a delivery truck for the diuretic itself, and that delivery function is absolutely crucial. Here's the deal with furosemide. Almost all of it, like over 95%, latches onto albumin as soon as it enters the blood. Now, that's not a bug, it's a feature. The drug is designed to do that. The albumin basically chauffeurs the furosemide right to the kidney. But in really sick patients, especially those with liver or kidney disease, their albumin levels are often super low. So what happens? The delivery system completely collapses. There just aren't enough trucks to get the drug where it needs to go. Okay, so the theory is elegant. It's a perfect pharmacological story. But when we move from the blackboard to the hospital bedside, that beautiful story gets incredibly messy. A big meta-analysis from 2021 kind of says it all. They found that therapy might work, but, and this is a huge but, the results are plagued by high heterogeneity. What does that mean in plain English? It means the clinical trials are completely all over the place. Some show it works, some show it does absolutely nothing. There's no consistency.
But here's where it gets really confusing. That same analysis did find a positive signal. On average, patients who got the albumin booster peed out an extra 31.45 milliliters every hour. And that's not nothing. It's a specific, statistically significant number. So case closed, right? It works. Well, not so fast.
It turns out that benefit is like a flash in the pan. Study after study shows that this diuretic boost, it peaks and then it completely vanishes within about 8 to 12 hours. So it's a temporary patch, not a long-term solution.
And you know, there's an even deeper problem here. Just getting rid of water isn't the whole game. The real enemy in edema is the salts, because salt is what holds onto the water in the first place. And while this therapy gives you a modest boost in peeing out water, its effect on getting rid of the actual salt, well, that's much weaker, much more uncertain. You might just be treating a symptom, not the root cause.
And it gets even more stark when you look at a condition called nephrotic syndrome. These are patients who leak tons of protein and seem like the perfect candidates for this therapy. But the Cochrane Review, which is basically the gold standard for medical evidence, they were just blunt. They said they have very little confidence and the evidence is of very low certainty. In the world of medical research, that is about as damning as it gets.
So this brings us to the core mystery of the whole thing. Why? Why does such a beautiful, logical theory fall apart and produce such messy, disappointing results in the real world?
Well, the answer is because our bodies are just infinitely more complex than that simple two-step model suggests. It really boils down to three key reasons why the theory and the reality don't match up.
First, there's what's called the underfill versus overfill problem. See, not all fluid overload is created equal. Some patients are underfilled, meaning their blood vessels are actually low on volume, even though their tissues are waterlogged. For them, adding albumin makes sense.
But many other patients are overfilled. Their blood vessels are already stuffed to the brim. Giving them more fluid with albumin could be useless or even harmful. And the problem is, the early studies just threw all these patients into one big bucket. Second, and this one is just fascinating, is the albumin paradox. So in the bloodstream, albumin is your ally, right? It's the delivery truck. But in patients with nephrotic syndrome, their kidneys are leaky and they spill albumin into the urine. And once it's there, in the kidney tubule, it becomes an enemy. It actually grabs onto the furosemide and deactivates it, trapping it so it can't work. So the very protein you're adding to help might actually be part of the problem at the finish line. And third, there's something called the breaking phenomenon. Basically, our bodies hate losing salt and water too quickly. After that initial burst of fluid loss from the drug combo, the body's own systems freak out. They hit the panic button, releasing a flood of hormones that scream at the kidneys to hold on to salt and water for dear life. This powerful counterattack is exactly why that benefit just fizzles out so fast.
Okay, so if this combo isn't a magic bullet for everyone, where does that leave us? Is it totally useless? Well, not exactly. The evidence is starting to suggest it might not be a standard treatment, but maybe a niche rescue therapy for very specific situations.
So who are these very specific patients? Well, when scientists sifted through all that messy data, a few clues started to emerge. The therapy seems to work a little better in patients with severely low albumin, in those who get a bigger dose of it, and maybe in those who already have kidney dysfunction. This paints a picture of a short-term, break glass in case of emergency kind of treatment, not something you'd use routinely. And this table really brings it all home. Context is everything for albumin. Using it as a general diuretic booster, not recommended. The evidence is just too weak. But for specific life-threatening complications of liver disease, like after draining a huge amount of fluid from the belly, or for a nasty infection called SBP, or for hepatorenal syndrome, albumin is the absolute standard of care. It's recommended in guidelines because there's strong evidence that it actually saves lives in those settings. So, after going through all this, let's just zoom out. What's the big picture here? What's the ultimate lesson from this whole fascinating, controversial story?
At the end of the day, the story of the albumin booster is a perfect case study for why we need evidence-based medicine. It is such a powerful reminder that even the most logical, most intuitive, most common sense ideas in medicine absolutely have to be put to the test. A beautiful theory, on its own, just isn't enough.
And that kind of leaves us with one final thought, doesn't it? When you see a beautiful theory like this clash so hard with messy reality, it really makes you wonder, what other things that we take for medical common sense might not be so sensible after all?